Right, well, good afternoon, and I think it's a great turnout for our first lecture in a 5-series start off, well, really to the end of this year, which I hope we will go on to continue into next year. My name's Andrew Burston. I've been around here for a long time, but I'm currently the Clinical Director in Medicine, but also got the hat as the Director of Research Strategy at the moment. It's my pleasure to introduce Jonathan Karnon. Now, Jonathan is a health economist, and for researchers, I think we all know that it's pretty hard to get significant research funding unless you have a health economic evaluation of what you're doing. So that's pretty important, but I think it's more important even for the whole organisation that we start to understand what are some of the issues, how we evaluate them, how we make decisions, how we improve what we're doing, and that's the basis for which we're heading up with this 5-lecture series. Rob Padbury's here. He's going to be a major contributor as well, helping us with some of the improvement aspects, and so I think it's really going to be quite a treat. I know we've got a lot of people online as well, and we've got Slido, which is going, we can't get internet access here, but it's going through the phone. We've got phones, we've got phone access, so get on Slido. Apparently there's one question up there already. We'd like to use that and get everybody connected. So thanks, Jonathan. I'll just hand over to you.
Thanks, Andrew. It's a great pleasure to be here at Southern Adelaide Local Health Network. So I have to spell that out because there's people online from New South Wales and potentially further afield attending this seminar series, which is part of a broader community of practice. So for those of you who aren't aware, that alongside this seminar series, there's a community of practice being set up to support the use of economic evaluation in local health services. So that's the purpose of the community of practice. So I'd encourage you all to look that up and sign up. So as Andrew said, this is the first of 5 seminars, and so this is really very much an introductory seminar. We've got 5, so there's no need to rush. And the other thing I want to point out from the title is that I've phrased it, how could economic evaluation be used in local health services, ? So I'm not coming with all the answers. This is definitely a two-way process, so I can talk about the methods that we could use, but people within health services need to provide the context. So I'm really putting some suggestions forward, some proposals, with the aim of generating some discussion. So I'd just like to start by acknowledging the traditional owners of all the lands that attendees to this seminar are located, and honour their elders, past and present. Also just need to acknowledge the funders of the work that kind of surrounds this seminar series. So the Embedded Economist is the project on which this seminar series is based, and that was originally conceived by New South Wales Regional Health Partners, and Wendy Keach and Health Translation SA have kind of picked it up in South Australia, and so we've had some funding through the MRFF for that. But my funding up until this point has been through the NHMRC Partnership Centre in Health System Sustainability, which you can see here has a range of funders. So just to acknowledge all of those contributors without which this wouldn't be possible. Andrew mentioned Slido. So if you haven't used Slido, you simply go to slido.com, you enter the event code 9285, and then you'll be able to see questions that have been asked, and you'll be able to ask questions yourself, and I'll be monitoring questions, and people will be monitoring questions and letting me know, so we'll get it working. All right, so that's all the introductory stuff out of the way. So I just wanted to start by recognizing that this issue of how to use economic evaluation in local health services is not a new issue, and health economists have been looking at this issue for a long time, as you can see here, going back to 1995, and these are 3 Australian studies. So there's been a lot of work overseas as well, but you can see in Australia itself, people have been looking at how economic evaluation could be used and why it's not used. And so you can see here some of the issues that have been raised in the past, that the evaluations have to be more relevant to decision makers, have to take context into consideration, and then this last one in 2015 talked about the time and cost required to conduct and interpret evaluations, but also to incorporate them within decision-making processes. So those are the challenges that we're trying to address in the Embedded Economist and the community of practice more broadly. So the way I see it is there are three broad areas or opportunities for using economic evaluation in local health services. The first is around prioritization, essentially. So providing more information to inform priorities within local health services, and that will obviously be specific to different services. The area I'm most interested in, I think, is the second one, which is around service design and using economic evaluation to inform the design of what we hope to be cost-effective interventions before we actually implement them. And then thirdly, there's probably the kind of traditional, what we think of traditionally when we think of economic evaluation, which is doing an economic evaluation of an implemented service or technology. And so we're going to cover all of these aspects over the course of this seminar series. But today I wanted to just provide a background, set the scene as it were, to how economic evaluation is currently used across the Australian health system as a form of comparison for how it's used or not used in local health services, and then just touch on some of the issues that are relevant, that I think are relevant to why economic evaluation maybe isn't being used to its fullest potential in local health services. So everyone's on the same page. A very basic definition of economic evaluation. So it aims to inform decisions that increase the value of the health produced by the resources allocated to health and healthcare. So a lot of keywords in there, but it's not making decisions, it's informing decisions. It's not saying what is the value, it's eliciting the value of health produced by scarce resources. So I thought it was maybe good to address some of the conceptions that people have about economists head on. And this is I guess one of the kind of, well, I was going to say misconceptions, but maybe it's not. Maybe it's a true conception of how economists kind of like to think the world ought to operate, where we live in a world where there's perfect information and we have rational decision making. And so we can kind of take that as a starting point, as our kind of idealized world, and see how far we have to move away from that idealized world in different contexts. How far do we have to move away from this assumptions in the context of local health services, for example? And so if we were living in this idealized world and we identified a new intervention and we estimated the cost of that new intervention and we estimated the expected benefits of that intervention, so it's going to cost $1 million, for example, it's going to delay the deaths of 100 individuals, then we would ask, can we identify currently funded healthcare that generates less highly valued outputs? So it may not be delaying death, it may be generating improvements in quality of life, but those outputs wouldn't be valued as highly as delaying the death of 100 people that cost $1 million. So we're essentially saying, can we identify something we're currently doing that we can stop doing in order to fund this new intervention? But that would only be the first step. We then have to ask, is there any other form of healthcare that we're currently not providing that generates more highly valued outputs than those associated with delaying 100 deaths that also costs $1 million? And so that's an example of the type of information that we'd need to be able to make perfect, rational decisions. I just wanted to highlight my colleague Brita's book, which goes into these arguments and these issues in a lot of detail, and it's quite an entertaining read. So it's talking about how we make decisions about reimbursing new drugs, but it's equally applicable to issues around decisions to invest in health services, in local health services. But the first port of call in terms of the real world is how economic evaluation is currently used by the pharmaceutical benefits and the medical services advisory committees, who are the primary users of economic evaluation in Australia. And so PBAC and MSAC, as you know, evaluate new pharmaceuticals, new medical services to decide if they should be funded and listed on the MBS and the PBS. And almost always they're looking at new technologies that cost more than current practice. And so the question that they're addressing is, do the additional benefits justify the additional costs? What they don't ask are those two questions that I alluded to. So they don't ask whether there's currently funded healthcare that generates less highly valued benefits, and neither do they ask whether there's other new healthcare that is expected to generate more highly valued benefits. So they're making decisions in isolation. And so you could argue that they've not moved too far away from our idealized land of the economists. So they've moved from flying pigs to something quite similar. In fact, the joke that I was weighing up whether to make or not was, what's the difference between a flying pig and Donald Trump? The letter F. Sorry. So PBAC and MSAC are making assumptions that lower value healthcare will be identified and stopped in order to free up resources required to fund new pharmaceuticals and medical services, and that there are no other forms of healthcare that could be funded that would generate more highly valued benefits. And so the point that I'm kind of starting with here is that decision making is very different in local health services, that it's simply not possible to make those assumptions when evaluating new health services. The other important point to set up front is how PBAC and MSAC undertake economic evaluations. So the first point to note is that they take a government health system perspective on costs. So when they're estimating the costs associated with new interventions, they take a government perspective. So whether it's costs incurred on the PBS, the MBS, or in public hospitals, it's all originating from a government budget, and that's the perspective they take. And as we'll come on to later, there are many different perspectives that can be taken across the health system, and those perspectives can be important in terms of using economic evaluation or undertaking economic evaluation. And the second point is how they represent benefits. So they use the quality adjusted life year as their measure of benefit. And so a lot of you will have heard of the QALY, but a basic definition is a 1 QALY is equivalent to 1 year of life spent in perfect health. And the reason that it's used is that it enables the capture of both improvements in life expectancy, but also quality of life in a single measure. And that enables us to compare benefits across clinical areas. So we can use the QALY as a measure of benefit for whatever health technology or service we're interested in evaluating. And as a result of the fact that PBAC and MSAC are the main users of economic evaluation, almost all published economic evaluations take a health system perspective, and they mostly are valuing or estimating the value of healthcare that's more costly than current practice. So it's quite a thin strip of the potential interventions that could be evaluated and taking a single perspective, which may not be relevant to every decision maker. So, from my understanding, in local health services, the health system perspective may not be as relevant because local health services have their own budgets and they're not as interested potentially in spending on the MBS and PBS or cost impacts on the MBS and PBS as PBAC and MSAC would be, for example. But also it's not impossible, but it's certainly more challenging to fund new healthcare that costs more. And so I think those are two of the key differences between decision making in local health services and decision making at a Commonwealth, PBAC, MSAC level. So where we're at in terms of the use of economic evaluation in Australia is that it's used to inform all decisions to fund new pharmaceuticals and medical services. It's used sometimes within state health departments, and it's difficult to assess the extent of the use in state health departments because it's not as transparent. So we know that PBAC and MSAC use it because they publish public summary documents. You can see exactly how they're using economic evaluation. State health departments is a little less clear. But it's certainly my understanding that it's rarely used in local health services to inform decisions about where resources should be allocated. And so to me, this means that firstly, we've got less information about the value of interventions that could potentially be funded by local health services, but also that there's potential to improve local decision making using economic evaluation. I guess that's why we're here. So just to kind of set the scene a bit more in terms of our focus, I guess my underlying assumption is that local health services are less concerned with which particular technologies, pharmaceuticals or devices are going to be used, that those decisions are increasingly being made at a state level. And so within local health services, there's more of a focus on improving the organisation and delivery of healthcare. And so a focus we may describe as being on healthcare delivery models. So we're interested in evaluating, designing new healthcare delivery models that improve performance and outcomes. And just to note that there is a mountain of evidence out there on the effects of different healthcare delivery models. So this is a review of systematic reviews of healthcare delivery models, and they found over 500 systematic reviews. So there's a huge amount of evidence out there. We took a similar review, but looking just at Australian evaluations of healthcare delivery models, and found almost 700 published evaluations in the last 10 years. And so you can see here we're asking the question, are we making the most of this evidence? And clearly it's not as straightforward as saying, all right, this works, let's do it. You've got to take the local context into account. But that's, I guess, what we're trying to address here is how can we make better use of this evidence, of other evidence? What evidence do we need to inform, to better inform decision making in local health services? So this is John Maynard Keynes, one of the most famous economists. And the reason I put him here is another little, I shouldn't introduce my jokes, should I? But it's, I was thinking about, well, what am I trying to achieve? And originally I thought short run and long run, but then I was reminded of Keynes, who said, don't talk about the long run, because in the long run, we're all dead. So in the short run, my aim is to think about and work towards how to use economic evaluation within local health services. But in the medium run, my aim is to generate more evidence on the cost effectiveness of healthcare delivery models, so that we can compare the value of investing in healthcare delivery models with investing in new technologies. And that doesn't mean that we'll necessarily fund fewer health technologies. It may mean that we can actually negotiate better on price when we're negotiating on pharmaceuticals, for example, at a Commonwealth level. And just as a side note on Keynes, as I was kind of looking up this quote, I came across the fact that he was actually the inventor of the "you only live once" generation. And as we can see here, someone has said Keynes knows what's up, which is, I'm sure he wasn't expecting that when he was putting together his general theory on employment. So some examples of, so in PBAC MSAC context, we talked about the fact that they're almost always looking at technologies that cost more and generate better health. But in a local health service setting, there are other types of interventions that we might be interested in evaluating. So firstly, we might want to evaluate existing services to determine whether they are providing value for money, or potentially we could divert resources. And so this is an evaluation that we undertook a few years ago. Clara's in the audience. And I'm not going to go into it in detail here. I'll come back to it in future seminars, because it provides a bit of a cautionary tale. But we essentially were invited to evaluate this preoperative physician-led clinic for high-risk surgical patients that was being delivered at the Queen Elizabeth and the Royal Adelaide, and to inform a decision about continued funding of that service. Another type of intervention that may be more relevant from a local health service perspective are interventions where you're potentially investing to save. So there's upfront costs, but there's an expectation or a hypothesis that you're going to save costs down the line. And so an example here would be investing in weekend inpatient rehab services with a view to reducing length of stay, essentially. So in summary, the three broad uses for economic evaluation, as far as I see them. Firstly, in terms of evaluating new interventions, we've got those that cost more, but we expect to generate additional benefits. We've got those where there's upfront costs, but we expect to save downstream. And then there's evaluating existing interventions with a view to informing decisions about continuing or modifying those services. So now moving on to the issue of perspective. So perspective is everything, and it's certainly the case when looking at economic evaluation. So I'm going to use this example of a cost effectiveness analysis of an intervention to reduce emergency readmissions among older patients. So this was undertaken in Queensland. The intervention involved nurses and physiotherapists putting together an individual post-discharge exercise plan. Post-discharge, there were home visits with telephone follow-ups by the nurse to maintain contact, and I guess an early warning system for patients. So skipping to the results, if we were taking a health system perspective, then we would interpret the results in this way. So the intervention was estimated to cost around $550 more per patient. The main effect was a reduction in bed days, around half a bed day per patient. And from a health system perspective, that was estimated to be equivalent to a cost saving of around $333 per patient. They also measured quality of life gains over a follow-up period, and on average, patients in the intervention group gained around 1.5 months in perfect health, so the equivalent of an additional 1.5 months of life in perfect health. So the cost difference, $212, divided by the gain in QALYs, 0.118, gives us an incremental cost per QALY gained of just under $1,800 per QALY gained. And so that's the information that, for example, PBAC or MSAC would use if they were interpreting this, the results of this economic evaluation. And to put that into context, both PBAC and MSAC would generally consider new technologies to be cost effective and i.e. fundable if they gained QALYs at a cost of 40,000, and in some cases quite a lot more than 40,000. So if we think about, so it would be a tick, it would be funded if MSAC and PBAC were looking at this intervention. But that also allows us to think about what are the opportunity costs, the potential opportunity costs of paying $40,000 to gain additional QALYs. So if we invest $1 million in a new pharmaceutical that's costing $40,000 per QALY gained, we're gaining 25 QALYs for that $1 million. If we invest in this new healthcare delivery model, if we believe the data, and we're gaining QALYs for every $1,800, then $1 million is buying us, to put it crudely, 556 QALYs. So that's an additional 531 years of life in perfect health from spending $1 million on this new healthcare delivery model as opposed to a new pharmaceutical. So I'm just putting that out there to give you an idea of the potential effects of generating more information, more evidence on the cost effectiveness of healthcare delivery models. But as I say, perspective is everything. So how would a local health service potentially look at the results of that economic evaluation? And so that got me thinking about, sorry, this is joke number 3. That got me thinking about the ultimate question, which I always thought was something about, the meaning of life. But from talking to people in the health service, it's become apparent to me that what is the value of a bed day? So whenever I go and talk to people in the health service and people who are doing evaluations of new healthcare delivery models, the question is always asked, what is we can show that we're saving bed days, we're reducing length of stay. What's the value of a bed day? Because they recognize that it's not possible just to say a bed day is worth $600, because that's how much it costs to keep a person in a bed, for example. So there are different ways of looking at the value of a bed day from a local health service perspective. If it's possible to close wards as a result of reducing length of stay, then clearly there are resources saved, and it may be appropriate to put a simple dollar value on that bed day. Another way of looking at it is to think about the differences in costs and revenue. So public hospitals are funded through an activity-based funding system, and so if we reduce length of stay, potentially, we're reducing the cost of treating that particular patient who's been discharged early, but maybe the funding is not reduced, and so the local health service is making a gain financially in that regard. And so just to talk you through that process, this is the National Weighted Activity Unit calculator. So for every inpatient separation, you identify the DRG, you enter the data, in particular around length of stay and a few other variables, and at the bottom there you'll see a price is calculated, and that's the funding price for that particular patient. So here we've got a stroke inpatient separation of intermediate complexity, 20-day length of stay. The price as activity-based funding price is $12,124. If we reduce length of stay for this particular patient to 19 days, you can see that the price comes down to $10,766. So in this particular example, we may have reduced costs, but we've also reduced funding. If we reduce length of stay another day to 18 days, you can see the price doesn't change. So it's remained at $10,766, and that's all to do with the inlier length of stay bound, so the lower and upper bound. So 18 is within that bound. So if you're reducing from 18, the funding doesn't change until you get to 2 days length of stay. So there's a potential financial impact in terms of the reducing length of stay. So costs reduced, funding is not reduced, surely there's a cost saving. Well, it's not quite that simple, because clearly if you save a bed day and you don't close the ward, then that bed day is going to be used to treat another patient. And that's going to incur potentially more costs, because it generally costs more to treat new patients than existing patients. But then would you get more funding for the new patient? Well, at a state government level, you may do. So the Commonwealth fund 45% of the ABF price for growth in service volume, and that's capped at 6.5%. So there's some movement of funds, but that's to the state government. At the local health service level, it's my understanding that in the short run, certainly, there wouldn't be much impact on budget. So the local health service doesn't get additional funds because annual budgets are fixed. I'm getting a nod from Sue, so I'm happy. But I guess what I'm getting at here is quite complicated in terms of the funding mechanisms and the incentives and how you interpret these impacts when you don't take a health system perspective. If you take a health system perspective, it's easy. You know, you reduce length of stay, therefore it's costing less to treat this patient. The government is spending less on treating this patient. But from a local health service perspective, it's a lot more complicated. Now, this was an interesting study, again done in Queensland, where a group of health economists quite impressively got 37 CEOs of local health services to respond to a willingness to pay survey, where they described a scenario in which they could, the CEOs had the ability to invest in an infection control program that would save 730 bed days. And the responses are quite instructive. So 25% of CEOs said, nah, wouldn't be willing to pay anything because it's going to increase costs in the short term, as I described. Another cohort of CEOs referred to performance measures, so in particular the National Emergency Access Target, and they were kind of making the calculation that, all right, if we save bed days, we'll improve our performance and in particular our NEAT, more likely to meet our NEAT targets. And then other CEOs stated they were happy to pay for the beds because they anticipated being able to close their wards. So there's 3 very different responses to this opportunity to invest to save bed days. So on average, the willingness to pay was $264. But you can see that within that, there's a lot of variation. And clearly, it will depend on the context and the priorities of different local health services. So from a local health service perspective, if we were looking at this intervention where the cost is real, so it's going to cost $550 to invest in this intervention. The reduction in bed days, we would expect a reduction in bed days, but what's the value to the local health service? And then in terms of the QALY gains, again, it would be nice for decisions to incorporate costs and benefits, but there is a question as to how relevant those measures of benefits are to local health service decision making. So the way I see it is that to fund this intervention requires one of three scenarios. Firstly, the local health service has got budget capacity to invest to improve outcomes. Secondly, it's selected as a prioritized option to increase capacity, so focusing on the bed days. Or thirdly, there's potential to request to make a business case to request additional funds from state government to fund this intervention. So my summary is that I've kind of split the potential role of economic evaluation in local health services into in research and in practice. So from a research perspective, my aim would be to demonstrate the value of improving local health services and to analyze that value from different perspectives. So then we can explain why cost-effective interventions are potentially not being funded by local health services. So the aim there is a deeper aim to kind of inform policy at a higher level. But in practice, I think and hope that there is potential to use economic evaluation to inform solutions to priority issues within local health services, and that might be through helping to understand problems and current practice, to design solutions as well as to evaluate and demonstrate the value of implemented solutions. And that process should strengthen business cases, which will then improve decision-making processes around resource allocation decisions. So that's where I'm going to stop today, but just to highlight the remainder of the series. So this has been very much an overview of economic evaluation. In subsequent seminars, we'll get more into the detail of how economic evaluation could be applied in practice in local health services.
Thank you, John. John, you stay there because there might be some questions from the audience. I don't know whether we've got anything from Slido there, but some of us don't know much about economics. That's probably pretty obvious in our position, but so the only economist I've read recently was Dan Kahneman, which was the Thinking Fast, Thinking Slow. And I was thinking about that when you were talking, because one of the things that was so interesting to me there was talking about how people value loss and value gain. So when you tell me that something is not as valuable as, it's better, we would be better off to stop doing one thing and do another thing because it's more valuable. Well, I think Kahneman and Therese decided that, it looked like it was about a 4-to-1 ratio between how we value loss. We overvalue loss. It's not a 1-to-1 thing. So do you think that's real? And then if that is real, how does that get into our discussions? Because I think what happens is we bring that bias with us sometimes, and then we decide that the information that you're inputting in here doesn't look quite right to us. So how do we think about that?
So the whole issue of, it's called the disinvestment field, and economics is only one input to that, or economic evaluation is only one input to that whole process of assessing the value of what we're currently doing and whether we should stop doing things and invest in new things. And it's been shown to be very difficult to persuade people that maybe what they're doing isn't as valuable as they think it is, or that there's more valuable things that you could be doing. So it's definitely that's one of the issues that maybe we'll get to address.
That's good. Everybody's noticed I've got some pajamas and I'm doing some clinical work this week, but people might value the clinical work you do differently to the way you value other things.
2 questions on the slide.
Do you want me to read them out? Okay. Well, Michelle in the audience here sent the term cost-effective appears to be used inconsistently across health. Does Salin have the right information to make decisions based on cost-effectiveness? Well, I guess my answer to that would be no, and that's kind of, yeah, I guess that's what we'd be hoping to try and address is what information is most useful to inform decisions that Salin are making. Yeah, and we'll get into that, I guess, more in subsequent seminars. Yeah. And then there's a question about how are QALYs relevant if the health benefit is being measured in already seriously unwell individuals and long-term chronic health conditions and disabilities. So, yeah, that's a technical question that might take on notice, but yeah, the QALY is not perfect. It's certainly lots of limitations, and that's why I said right at the front that economic evaluation is to inform decisions, it's not making decisions. I guess that's an important aspect, is the people who are making decisions using economic evaluation need to be aware of the limitations and how to interpret the outputs.
Rob, every yeah, I mean, it's very, very interesting and fraught subject in many ways, but in the public health sector, we have to balance an upfront investment in kit, and as you say, buying kit is real money. And often we balance that against reduced length of stay. So if you take, for example, the revolution of laparoscopic surgery, dramatically changed the horizon, particularly with length of stay. But in fact, in an economic analysis in the public sector, it wasn't all that much use to us because we were just churning over more patients and that didn't really necessarily benefit. In fact, it cost us more money. So we were spending to buy the kit and then wearing yet another expense. And so there's not, in the public sector, there's not really a good way of valuing a bed day because it's often attributed rather than real money. Whereas buying the kit is real money off the top. And that conundrum is something that's really hard to solve. In the private sector, it's a complete no-brainer. And so even in the private sector, they can buy robots and run robots at a loss, knowing that it attracts other patients to the hospital and other procedures to the organisation. So overall, it becomes a bit of a marketing thing. And so they're running in a completely different paradigm. And working across both sectors, you become quite schizoid because it's really hard to assess value. So value, which is just not an economic thing, but is patient comfort, length of stay in hospital, immobilisation, how many opioids, all these things that go into it. That's not just money, and that would be a really good equation to sort out.
Yeah, and like I say, that's what I'd like to do, is undertake these economic evaluations from different perspectives. So if you take from the health system perspective, you show that something's massively cost effective. Then as soon as you take a local health service perspective where those costs are not relevant, or cost savings are not as relevant, then you get a different interpretation. So it's
not realisable as money, I guess.
Yeah,
That's the way I would describe it. And in that paper you referred to from the Katie Gibbs thing with the preoperative physician assessment, what was the answer?
The answer wasn't positive from the clinic's perspective, but there were lots of methodological issues, and that's why I wasn't going to get into the detail.
But you published it nonetheless.
Yeah.
The surgeon said otherwise, so the qualitative component too, because it wasn't reflecting what we were expecting.
So what you're saying is the surgeon's word is more valuable than any economic analysis. This is something I'd like to get to this. The mantra, I like that.
It sounds like medicine intervention at that stage. Sue.
John, thank you very much for that and for taking and working with us on this initiative. And we've got Wendy here as well, and thanks team. I think it's a really important part of our journey forward. And you know, these are incredible conundrums that we deal with every day. And I think our big issue is that, and I go with Michelle's words, you've got cost effectiveness, productivity, efficiency, you know, low value, high value, volume versus value, all of those sort of things. And so there's been this sort of nomenclature that's been created that we as our local health network haven't got a common sort of view about what that means. So I think there's some real work in that. I think the other thing is the context this has to sit into, which you make the context from a broad, you know, national perspective in relation to something like the farmer sort of conversation, which is pretty, you know, unit measured and pretty definable, versus some of the other things that we talk about the, you know, the 85-year-old person who's, you know, got a social deterioration and, you know, et cetera, and our activity-based funding that comes with that. So I think there's a really big issue about understanding how a context makes a difference to the assumptions you put around the economic analysis. And what I mean by that, I've worked in a number of different state jurisdictions, and depending on your population growth, on your economic drive from a department point of view, whether you actually have got strong population growth, which can sometimes relates to activity growth, it doesn't always, but it can. All of that makes a difference to what I call the release money that allows you to seed and fund new initiatives to test and trial. And I think one of the big issues that we see in any economic story is the inability to do a return on investment model over any period of time, because we really have a 12-month budget, and we don't have any sort of forecasting in that. And we have often we're only getting our budget in October, so we really got a 9-month budget. By the time you hit February, you know what your budget's going to be anyway. So your room to move to do anything and to pull the levers and what levers you've got. And I think that's what we've got to understand to truly sort of point to Rob's point about how do we make this actually not potential, because there's lots and lots of potential, but there's very little in the realisable. And I think that's the nut we've got to crack, because there's so many consultants can come out and we can do all the theory on potential. We received a document the other day that say, here's all your low value care, it's worth multi-millions of dollars, just fix that up. There's your gap in your budget, off you go. But how do you make that realisable? And actually truly, as Rob says, release the money to have it freed up to put into something else. And I think that's the conundrum, and if we can work to solve that little small problem,
I'm glad you're not asking me for an answer now. But yeah, no, I'm really looking forward to it. I've really enjoyed over the last 18 months working here with Salin, so it's been great.
Just give everybody one more chance to think, but and this is pretty basic, it just probably shows you my lack of understanding, but I saw your 730 days up there that you might save, and I realised that was 2 bed days.
It's 2 beds, I know, that's what I thought too.
And we had that, we actually had a method to save 2 bed days, but it wasn't very effective because it didn't fit our nursing ratio, which we run at. So we couldn't actually decrease we couldn't get a real saving on that. All we could do was increase capacity, but the alternative, of course, which I realised, I guess that's the value of having somebody like Speak takes it to a different place. We hadn't thought about it. Maybe we could close 4 beds half the year, and that would be 730 bed days. So we hadn't thought about it quite differently like that, and so we're going to come back with a new plan, I guess. But I guess that's the value of having some of these ideas here. So there are no more questions.
Andrew, we've got some on Slido.
Another Slido for you?
A few more.
Oh, gosh.
Okay, I'll leave that with you.
For a few minutes, otherwise.
To understand the it's gone. Understand the disinvest and reinvest, but what if you're wanting more of the same to reduce a wait list? Well, more of the same would be an invest, I think. So I think that would be but you still want to know what you're investing in or doing more of was good value, because it's still an investment. Oh gosh, it's me. In a competing system, when the value of treatment outcome is not shared, who would decide the highest priority? Clinicians, executives, chief financial officers, individuals?
Community
Community. Wendy says community.
Well, no, just saying.
Yeah,
that
yeah,
it's
yeah,
next.
yeah,
You
yeah,
know, we
yeah.
should be having a community view of these things.
Yeah, yeah. I think is that it? Yeah. All good.
Okay, John. Well, thank you. Great start. Look forward to the next 4, and then we've got to see what we're going to do next year. But
Yeah.
that's a great start. So thanks very much, and please join with me.
Thank you.